Shall we start? Cindy,
Okay, Doctor.
on cameras.
Okay.
MOs on cameras.
Wait. Okay.
Yesterday, this one.
Yeah, Doctor. So I present both also is from yesterday. Mm.
Go on.
Okay. Okay, good morning to all specialists, consultant, and my fellow colleagues. So today I will present my cataract surgery video, which was done yesterday. So my first patient, this is the first patient, which is a 67-year-old Malay gentleman with underlying diabetes. So he underwent right eye cataract surgery yesterday. His presenting vision was 660 with an axial length of 23.63. The IOL inserted was the Hoya insert lens. So for now, I can only do from the nucleus management onwards. So the initial part was actually done by Dr. Isha until the cracking of the nucleus into a two heminucleus segment. So this one is already a CCC done and the hydro dissection already done by Dr. Isha. So he actually helped to crack the nucleus into half first, because this nucleus actually didn't look a bit soft still, so was worried that I might struggle during the chopping of the nucleus segment. So I will fast forward a bit. So to chop the nucleus into two segments, so Isha thought like have to do just a short groove so that able to grate on the nucleus. I forward a bit more to the part I do, Doctor.
Go ahead.
Yeah,
Tak
so
comment lah.
the nucleus have already been chopped into heminucleus segments. Okay, so yeah, so this is me starting to do the surgery. So okay, so initially I already rotate the sorry, I think a bit too fast. So I rotated the segment so that I am the nucleus hemi segment is directly central in front of my probe. Then the nucleus is actually not too hard, so able to luckily I was able to successfully crack the nucleus into another small quadrant. Because so far actually I have been having some problem, like sometimes I'm not able to crack, and then yeah, sometimes I'm able to, so still practicing the skill of chopping. So now I rotate the nucleus to the other half, and then going to chop it into smaller segments.
Your dialing all improved already, isn't it?
Yeah, I think I feel a bit more comfortable now doing the dialing motion, but then I think sometimes unintentionally I still tend to push the nucleus down when I'm trying to dial. So yeah, I need to practice more on that. So this one actually previously was already cracked, but not fully separated. So I just yeah, try to fully separate it and then remove out the segment and bring it into the AC.
The audience don't just look at the video, you look at the parameters as well.
Yeah, okay. Then yeah, I think my tether control, I'm still always very hesitant to press on the
All
phaco.
two.
So I realized most of my most of the time I'm actually at vacuum and then with
You're
very
at 2.
minimal.
So like
Yes.
you're mostly at 2.
Yeah.
Because so little. You look at FICO parameters, so little. Okay.
Yeah. Yeah.
Okay, learn your FICO foot pedal. Okay. All right.
Okay. Yeah. So most of the time I'm still always at only vacuum with a minimal amount of phaco. Yeah, I don't know, like I think it's the fear of the nucleus suddenly like surge forward and then because
They don't, because it all foot pedal control.
yeah.
And you
So
are at the
somehow
center.
I always feel more safe when I'm only at the second foot pedal level too. So I tend to always be in
Then your FICO will take forever.
yeah, but I
You look
realize
at
it's a bit long lah. So
yes, you look at your FICO, very little.
yeah,
You rarely press 3, and press 3 also very little.
sikit.
Tengok
Because the minute I
parameter.
hear the sound change already, then I tend to just like maintain sana to makan a bit, then I will go back to level 2.
Boleh komen tak?
Boleh,
Hey, go
Dato'.
ahead.
Okay, I think a good way to assess your foot pedal is masa you buat grooving, ya. Try to give some variation in the depth. When you do the the first groove, deepening the nucleus, you see at which pedal you feel comfortable, you know? When you groove, is what level? Is it just vacuum or is it your, so how deep is masa you the groove? So you more or less you can control and see what the effect of your foot pedal and what happened to your nucleus masa you groove.
Okay.
So sometimes it's important to do that part and be comfortable with that part so that you know where your foot pedal position was masa you buat grooving. So masa you chop, then you more or less gauge, because this part is important with masa, especially when you bertukar machine. Sometimes you want to change some of the machine, because the feel is going to be different. So the way to gauge is masa you groove.
Okay.
Okay.
Thank you, Dato'.
Yeah.
I think because like tak confident kan, so every time I feel that if I go, I'm always afraid that I overshoot and termakan too much and then hit the PC, which was what happened one week. So
with this kind of cataract, tak selalunya tak overshoot. Because it's a bit hard, unless it's very, very soft.
Yeah, so I
think you improve a lot.
I think actually I feel like the chopping technique is very not stable. Like sometimes I akan berjaya and then sometimes I don't. So so this yesterday both the cataract that I got was like okay, and I managed to chop. So this was the first one where it's not so hard. It's just mainly like nuclear sclerosis and some PSCC.
The concept is Cindy, if you have big chunk, you vertically chop it. Let's say you have quarter segment and you think it's too big, you vertically chop so that you don't drag the back. You don't the capsule.
Stretch it.
You don't compromise the capsule. When it is small, then you horizontally chop using your shaft. That's the concept. You don't take out the whole chunk, the whole hemi segment out of the back. That's the concept. And you need to chop it in the back.
Okay.
Small little before you pull it out.
All right.
Okay,
so
you're okay.
Yeah. For this case, so after that able to complete, there was no complication. Was able to finish.
You know when to do fast, Cindy? This is the time to do fast.
With
because
the other nucleus below.
Yes, the other segments are still there behind you.
Okay.
This is the time to do fast.
Yeah, but because Dr. B, because I have to actually see where the probe is most of the time kan. So when another problem is when it all floats up, then after I've chopped, then it tend to all like clog up at the phaco tip. Then I get a bit scared because I can't see exactly where the edge of the tip is.
This is the role of your second segment, second instrument. Get rid of it, then eat up one by one.
Yeah.
Make yourself systematic removal so that you don't miss anything.
Okay. So
the only time that you can slow down, you should slow down is the last segment.
Okay.
The rest of the segment you do super fast. You're safe. And as long as you're at the center.
Okay. Yeah.
But now sini you macam super slow. Power you doesn't exceed 20.
Yeah.
And the thing when all the pieces come floats up,
yeah,
what you can do, you can release, play with your vacuum and aspiration, release and press, release and press. So it will spread out balik. Then baru you boleh go and see better.
Because the minute the nucleus macam masuk sikit, I dah terkejut already. So I will straight away go back to level 2. Yeah, I feel a lot more.
Nampak kan parameter sikit kan, really.
Yeah. Yeah.
Macam mana nak masuk dalam, nak emulsify.
Itulah, like dia masuk pun I takut.
This is zero phaco, zero power phaco.
Yeah, I think a lot more room to improve on the pedal control, but I tend to okay.
The only time that you're careful kan, super slow is this one lah, the last segment. Yang ni slow.
Okay. Yeah, so I still lambat sebab memang takut lah.
Quite useful when you look at your parameters and then you know you can assess where we are looking at parameters.
Understand? Yes. So after this was like cortical removal. There was a few small segments, so I removed using IA only with the second instrument to help to feed it in.
Hey, the video is very good. What do you all do? It's very clear.
It's clear.
The line is clear. The line is clearer.
Oh, actually didn't change anything, Doctor. Just don't know, is it today the line is faster?
Clinic Unify lah, this one.
Tak. Doctor, using my handphone.
Oh, okay, very clear. Okay.
Okay. So after that is cortical removal, not much issue. Just that so for cortical removal, if the cortex like very small and near the equator, I actually don't dare to sweep beyond the areas that I can't see. Although the Isha and Dr. Ida always say it's safe as long as I don't go down and my the hole of the IA probe is facing up. I shouldn't catch anything, but still takut.
It's actually safe, no? Macam ni kan, pusing lah. Like yesterday, hilang, tiba-tiba hilang. Just turn your probe behind, then you can get it.
Okay. Yeah. So.
Do you all practice polishing the CCC?
No, didn't.
Isha ada buat polish CCC? Ida?
Saya depend. Kalau CCC tak berapa besar, okey saya buat lah. Kalau tak, biasa saya tak buat.
Tak tahu. People say it doesn't make difference. People have done research. But sometimes I do it routinely. Ida buat
Doktor.
Buat you buat CCC.
Tak dengar dulu.
Buat
Polishing
make a
of
difference.
CCC. Capsule.
Capsule CCC kadang-kadang kalau CCC kecil takut capsular phimosis. So sometimes I do it quite extensive.
Okay.
Tapi CCC dia rasa okey kot Doktor. Sebab kita ada buku tu kan.
Especially hard cataract kan, sometimes bila kita polish kan, dia nampak lagi clear. Lagi CCC tu lagi, because of epithelial cell lekat tu kan.
Okay. Yeah. So this is a Hoya insert lens. So after this, actually, not much issue later. The lens was stable, able to insert in the bag, and yeah, wound was stable. Didn't have to suture.
Someone asked, good morning, would like to ask what is the difference between vertical chop and horizontal chop? When do we decide which technique to use? Answer. Siapa kata? Who else? Shu? Siapa lagi? Stella semua? Siapa lagi? Mahani? Mana Mahani? Jawablah soalan. Dalam chat. Sini?
Yeah, Doctor.
Yeah,
okay. Should I go on to the next video, Doctor?
Yes.
Okay.
Who want to answer this chat? What's the difference between vertical chop and horizontal chop?
Is our
Concept-wise, the technique that we use, vertical
yeah,
chop meaning is vertical lah. Vertical, your
the
dialer
probe is
goes
towards vertically down, and then pulling.
Horizontal meaning we are slicing it horizontally.
Yeah.
But some other choppers, they use horizontal when they put the tip of the chopper to the equator and pull. That one is also horizontal. But we don't advise our trainees to do that. We don't really teach that technique. What we teach is the vertical chop at the center. At the center using Sinsky.
Okay. So this is the second case that I did yesterday. Also was I only did from the heminucleus segment onwards. It is a 76-year-old Malay gentleman with underlying diabetic and hypertension. So this patient has a white cataract with a vision of hand movement and an axial length of 23.65. The IOL implanted was a Technis lens ZXC-BU plus 20 diopters. So the initial part of the surgery is also done by Dr. Hishaha until chopping it into heminuclear segment.
Sorry, Cindy.
Yeah.
Please remember, jangan overstretch the lid. You just need the cornea. You don't need the conjunctiva tu, especially the inferior part. I think you stretch.
The speculum terlalu besar.
Alright. Cornea je kan. Nanti tahulah what can happen after surgery. Okay.
Okay, thank you, Doctor. Yeah, so actually this patient initially he tend to move a bit like so during the CCC creation, the CCC turned up a bit smaller than what was planned.
Intumescent, is it intumescent?
Actually the cortex is already started to liquefy, but not too bad. Still, it didn't like extend the CCC during the CCC creation.
Okay, Cindy, I want to ask, if it is extending at this point, what do you do?
So if it is extending, so I will stop first. Then after that, insert in more visco to tamponate.
Stop. You shouldn't stop. The moment you stop is when it is extending. The moment you stop, come out, and you take visco elastic, and it will extend. So what do you do immediately?
Pull towards the center.
Yeah, well, you can't already because it's extending. What do you do? Emergency. You shouldn't come out.
Shouldn't come out.
The moment you come out, it will just extend it. What did I tell you? Selalu cakap, what do you all normally do? Apa lagi dalam ni? I can't see the name. Salma tak ada kan?
Salma tak ada.
Ada COVID
Ya, dia jaga COVID.
You press the nucleus using your whatever that you have, needle or your trata. When it is extending, you quickly go to the center or near that. Just press it down. Just press the nucleus down.
Tap down on the nucleus.
Yeah, tap down or just kacau the vitreous. Sorry, the vitreous, but the cortex.
Oh, okay.
The intumescent cortex, just disturb that. Just kacau, then continue. Because why is extending? You know why? Because why is it extending?
Pressure, high pressure inside the nucleus.
Yeah, because the nucleus is pushing it out and pushing it out.
Yeah, okay.
Rather than taking time to get viscoelastic and everything, that's what you must do. Then
okay,
after
so
you
tap
press
it
it
down
down,
first.
yeah.
Okay.
Then you come out and take your viscoelastic, whatever, then press down and continue.
Oh, okay. Baik, Doktor. Yeah, because I always thought like if it's aesthetic already, then we will stop and take the
that's the reflex response.
Yeah.
Reflex response is to get viscoelastic, but the moment you get viscoelastic, it's already out.
Okay, faham.
Hello, Dr. Azizman here.
Mani.
Just want to ask, in this case, white cataract, the CCC look a bit smaller. Can I make it larger using the cystotom and like make another round so that it's bigger? But I know the risk of it can get extended by macam to me the CCC macam small, macam too small to proceed.
Depends on your technique lah. Depends on your depends. Macam ni dia chop dalam bag semua ni.
Depends on your skill.
Okay.
It's safer to me. Sometimes kalau you have difficulty to do phaco and remove the nucleus, memanglah you have to boleh carefully enlarge the CCC. Tapi kalau you worry about capsular phimosis later, it's safe to do after you have inserted the lens. Kan masa kita insert lens, you still ada viscoelastic like that, you have clear view of the back of the lens, that time boleh you enlarge the careful sikit lah sebab lens dah inside.
Sometimes it's more difficult to extend it to redo your CCC kan, to enlarge. It's more difficult than doing the phaco itself. Sebab most of the time we chop in the back.
Betul. So don't try lah, don't try. Concentrate on your phaco dulu.
Phaco dulu. Unless it's too small lah, which is unlikely kan. Ini okay ni.
But a bit small. So during the phaco also, I was a bit scared that I will accidentally catch the CCC and.
That's why duduk center, don't explore tepi-tepi dan tangkap CCC. Just stay at the center. No business for you to go outside because it's not soft. This is just a nice cataract to hold.
Yeah. Okay, so this cataract.
Nampak Isha chop tadi kan? This is nice.
Nampak betul. Yeah, so from here onwards, Isha gave me to take over.
Right. So you all watch, You all watch, Cindy. Dia dekat apa jauh sana?
Yes.
Supposed to be at the center. Supposed to be very near to the tip.
Okay. So this nucleus also was not too hard, just that it had a few like strands that are more adherent compared to the previous first cataract that I had. So Isha just told me to hold and then move the second instrument deeper to try and separate the fragment. So for this cataract also able to chop into smaller segment. So because the CCC is quite small, so to take out the segments, I divided it into further smaller, not into 4, but divided it into more than 4 segments before taking it out from the back to phaco. So phaco a bit to embed the tip into the nucleus only. Then after that, maintain at level 2 to hold vacuum. And chop the fragment.
What is your phaco power limit? Phaco parameters 20 there.
The max power is 40, but I never go up to.
Tak nampak dalam video 40.
Dia ada satu max power dekat sini, Doktor.
Ada Okay, there. The line didn't appear.
The line is here.
Okay. Line. Nampak.
But so like tak makan, tak tekan sangat until 40.
So this is a horizontal slice lah. This is as far as this technique is concerned.
Okay.
For someone who just asked earlier.
So so as I'm trying to slice it also, because then Isha is keep reminding me that the CCC is very small, need to be careful that I don't accidentally hook on the CCC.
Ishak, you notice tak, power tak ada. Kena memang
Yes.
power.
So saya dah cakap dengan dia dah. Saya cakap it's quite safe because the bag is support. I mean, ada banyak nuclear segment yang dalam bag kan. It's quite safe to increase the power. Tapi tapi tak apa.
Lagilah dia takut nak tekan. Remind the CCC.
Don't remind CCC. Power tak ada.
Sebab saya nampak masa nak horizontal ni horizontal ke vertical? Horizontal vertical.
Zero power FECO. It's all apa dia, aspiration vacuum dengan chop. You're safe, Cindy, if you press FECO power at this time.
Okay.
Because you're safe. It doesn't cost anything. You're at the center. You just press it. You don't press all the way. You don't press all the time. You press little kaki to on off. Try to on off.
Ini quite discipline in terms of dia punya FECO probe punya position tu, quite almost all the time in the center. Kalau takut sangat pun susah juga.
Okay. Baik, next I will. Okay.
Don't worry, Cindy. Isha is there. Don't worry.
Dr. Aziz, Shikin here.
Siapa dia?
Here. I just want to ask, is there any precaution to be taken during the horizontal slicing? Because as advised by you, we have to use the shaft instead of the edge of the Sinski, right? I mean the chopper, kan? So because sometimes kadang-kadang as a new learner, so sometimes we're quite afraid of of poking the CCC, like mentioned by Cindy lah. Is there any advice?
The shaft is only applied for Sinski, Sebab Sinski, the tip is small kan, it's short. So you can just run dancing around and you see it doesn't cost anything. If you use chopper, panjang kan, you shouldn't use that shaft sebab tip tu akan hook on the other side. That's why all these guys, they use Sinski. Sebab the tip doesn't hook anything. So that's why they managed to get the shaft. Kalau chopper jangan, chopper, the tip is long kan. So we'll catch whatever iris or CCC on the other side. Faham tak, Shikin?
Okay, faham lah.
Kalau Sinski is very safe. Sinski is very safe to use shaft.
Okay, thanks.
In fact kan, our Ong Zuan hari tu, dia nak design satu instrument. The shaft is a bit sharp, So that kind of thing. So I don't know whether he's doing that or not. Can you imagine the shaft is a bit sharp? Dia macam sharp so that you can.
So easier to chop lah.
This one is round.
Yeah, it's blunt. Okay.
This is called innovation. You can work on this. You know who can do this? Dental kan? They have this. We normally work with them to design instrument.
Okay.
The best people to design instrument is surgeon, because we know what we want.
True. Okay.
So imagine shaft ni kan? Imagine if shaft is a bit, part of the shaft is sharp, not too sharp lah. I mean it's thin kan, so they can slice it better. And the tip is small, so it doesn't hook anything.
So otherwise was okay lah, able to
Shikin,
finish.
does it answer your question?
Yeah, so thank you.
But in my experience and teaching trainees, the most difficult part for them to master is this horizontal slice. They can go up above the tip or below the tip.
That's true.
So the best is at the level of the tip, then you can fracture the nucleus.
One thing you tak hold your fragment sebab FECO you too low. Macam mana you nak slice?
Okay. Baik.
And then when you hold sini, you hold dekat in the middle. So dia akan jadi takut nak slice. You see this part first. Yang ni tapi the previous pieces tu you either you tarik ke belakang ataupun you ke depan. You kena stay in the middle. Baru dapat slice it perfectly.
Oh, okay. The segment pegang tengah sih. Because sometimes I feel I actually can like dia tak rotate until exactly dekat tengah-tengah kan. So I dah tarik dia keluar.
That's why you kena hold, tekan sikit tu. Sebab tu dia bergoyang-goyang. So you cannot hold it. If you cannot hold it, like take more chopping.
Okay.
No. Sebab nampak tak? Dia longgar. It's like having but this position is good. Tengok you ke depan balik kan? Sekarang okay. You kena pastikan you tengah-tengah because that's the deepest part of the eye.
Okay.
You know what? I like the hands. Your hands are all at the center kan, Ida? Dia tak gerak. Stabilize at the center and you're moving your left hand. So you're achieving this.
I like my lesson from that. I've got people chopping dekat tepi and then chasing after the nucleus last time kan. I learned my lesson already.
Very good. Very stable at the center. So keep it up.
Because Dr. Ida and Isha also always remind to always maintain the center when they notice I'm running a bit out. So
macam ni kan, it's worth polishing, you know. Tengok tepi tu. Macam dah gelap-gelap kan. So you need to polish the CCC. Nanti dapat capsule promosi.
Tak berani.
Macam buat?
Tak polish. Sebab takut.
Yes, kalau I would polish tepi-tepi tu. Yang ambil je Feco IA tu. You gesel-gesel je blunt tip tu dekat bawah dia kapsul. Straight slowly. Berani?
Tak berani.
Tak berani. Bolehlah sikit-sikit belajar.
Boleh.
Depan at least inferior half tu.
Power polish mode tu dia punya vacuum about 200 je kan? Ke 20?
Apa ya? Jangan letak polish dia. You use your IA mode, you control use the foot pedal.
Guna your kaki mode.
Kaki control.
Agak-agak belajar, agak-agak dia vacuum.
Jangan letak polish because when you put polish, everything will lower kan. So your CC will come down or you come up kan. Sebab dia semua turun kan. So you maintain your IA mode. Tepi-tepi tu just control using your foot pedal. You will go. It is safe.
Okay. Always takut like catch the.
No lah, he will not come into your probe because you're not pressing too much. Pressing little.
But to polish the CCC area, so I have to move actually just directly below the anterior capsule, is it?
Touch the CCC from below, from inside.
Itulah like tak berani bila. Okay, we'll try next time.
The best technique is to use bimanual IA kan. That one is the best. Kalau not polish. Very good.
I see. Okay.
We don't have. We only have coaxial.
Yeah. All right. So after this, actually no issues already. Also able to implant the bag. The wound was stable. Didn't need to suture. Maybe to maintain the AC. Yeah.
You need to go up to no need to hydrate, Cindy.
Sorry. Together.
All Fecos shouldn't be sutured. The wound kan.
But if I don't hydrate, because I memang start to hydrate from the side port first, but if hydrate the side port only, still tak maintain lah the AC.
You learn how much you press, how much you put from the second port. Because there's supposed to have internal lip kan, internal flap from inside kan. That's what you want to close up from inside kan.
Yeah, I think with my skill, I tend to still stress the wound a bit, so I don't tak berani kalau tak hydrate the wound before closing.
We'll try.
Okay. Okay, Doctor. So actually, this is my the case that I did yesterday. So after this, Shui will present. Hers.
All right.
Okay.
You're sitting different places, is it?
Yeah, because Shui went to Mawib today to see one patient first.
All right.
Hi, good morning, Dr. Aziz, consultant specialist and fellow colleagues. So I'll be presenting this case which was done last month. A 64-year-old Malay lady, underlying hypertension, diabetes, and dyslipidemia. She has bilateral cataract, so we are doing the left eye. And the axial length is 23.69, planned for ultracert 19.5, aiming at minus 0.27. So this is the case. So started off with the incision 12 and 3 o'clock. The cataract was not too dense. It was vision-wise was, even though left eye counting finger, the cataract wasn't the dense white or dense kind. It is still quite okay-ish.
Shu, can I just stop you for a while? At this part, Shu, can you stop for a while?
Okay.
Okay, this is okay lah, the wood, because I've seen some surgeon, not to mention not from Selayang lah, because I've just come across tengok, because I've been seeing from upstairs and pusat cataract, live surgery from upstairs. So when you create, some surgeon kan, they don't want to create the main wound first because they say takut collapse, and the AC collapse, then they can proceed. So some surgeon resort to doing slit knife 15 degree first,
okay,
and do intracameral, everything intracameral anesthesia, then do viscoelastic.
Yep.
There, can that's correct. So some people do that because they don't want the cement tear on the main wound.
Okay.
But what's wrong is when you put everything there, you create slit there, 15 degree, you put your intracameral anesthesia, put in, then you put you put vision blue.
Okay.
Right. You put vision blue, and then you wash out, AC wash out through the second port without main port, not created yet. What do you think is happening if you slit? Slit is very small, and the surgeon just wash out the vision blue within using that slit wound.
I guess because there is little space for the fluid in the anterior chamber to come out, so it actually creates a very high pressure in the eye.
Correct. If there's no pressure, where will this irrigated vision blue go to? If you
go elsewhere to the side.
You go behind. You go through the zonals. You go to the vitreous. Betul tak? When you do this, you have to think. It's not wrong to create the second port first, but not until vision blue. What you have to do is you do create that and put viscoelastic in, then create your main wound.
Okay.
Then create a main wound, then irrigate through the main wound, and make sure the fluid comes out when you irrigate.
Okay.
It's dangerous, shall I say, because you can have whatever, when your CCC is open, and when you have anterior capsule open, the PC can open up, and you have this explain your nucleus drop and whatever. Okay, sorry, okay, sure.
So over here, I irrigated all of vision blue. So I should leave a bit inside, don't need to fully flush all of it out. Then after that, reform back the anterior chamber with visco to prepare for CCC. So for this patient, CCC wasn't an issue. I was able to create a CCC, but it's on its size is about 6 millimeter or so. It's not smaller than the the ideal IOL optic size. But otherwise, yeah, no problems in creating CCC.
Sorry, Shu. I didn't realize before this. When you do phaco, is it usual you put the two incision 90 degree to each other?
That is
you do this way.
This is my comfortable position.
Comfortable angle.
Yeah.
Okay. Another thing, don't stretch out the lid also, remember, but I think you overstretch it in this video.
All right.
I just wonder, how do you do left eye superior? Okay, you're sitting okay.
Okay.
I
am
left right hand, using right hand, superior sitting left. Imagine, I can't do it. Because big size, right? Your smaller size, okay.
So far no issues. But I will change it a bit more to 11 o'clock and 2 o'clock if it is a higher sunken orbit, like in Indian patients with higher orbital, and I will change it slightly.
I think you should do it temporal now. You're good at it. Now you have to start temporal. Sit in temporal, wound at temporal. Bukan sit at superior wound macam mana? Sit at temporal, wound is at the superior temporal. Tak. You kena belajar now. You're good at it now. You kena belajar at temporal. Stretch up your wrist sikit. Challenge yourself. You dah pandai dah.
Okay. So this one initially clean up of the anterior cortical matter. So I changed it to initially chop. Second, I changed it to initially scalp. Now change it to chop for better vacuum, and then I change it back to scalp to get a small groove, so to be able to better embed the phaco head for chop. So in this case, I was given, I am not that good with Sinski, so I was first given by the scrub Sinski, so I thought I would try out with Sinski to chop, but then I am unable to.
Sure, you are not obligated to use Simski, for the sake of Dr. Aziz ke for the sake for the others. Tak, it's your own preference. Tak apa, as long as you get the thing done.
Okay.
Nicely. Okay.
So the problem I had with this was I had problem trying to get it deep enough to propagate the chop through. So the hole was okay, but the second instrument I couldn't propagate deep enough to get a comfortable chop. So I was struggling in the initial phase a bit to try to get the chop right.
No, chop is not about chopping, chop is about holding. Right?
Yeah.
Because chop is about holding. When you don't hold properly, then you can't get it lah. That's all. Kalau terlepas tu rehold lah, terlepas rehold.
So over here I decided to try again, and then I did a few attempts on this side, and then when I couldn't really get it, then I decided to try 180, the other side. I rotate 180 to try the other side, and at the same time I asked the scrub whether I could get the chopper instead.
This is hard nucleus.
The nucleus is quite hard, but it's not dense as the ones that we have seen. It's quite thick, the lens. Yes.
The idea concept in chopping is, can you imagine the thickness of the nucleus? You can't possibly hold the superficial part of the nucleus only with hope that you can chop the whole thing.
Okay.
Because of the thickness. So you have to go to the depth, the mid nucleus, the middle, to hold properly. Then only you can chop.
So this one with the chopper, I think because the tip is a bit longer, so it enables slightly deeper reach, so I could get half the chop. But the nucleus was still like Dr. Aziz mentioned, quite dense. So I now embed in deeper to the nucleus and try to crack that bit of the nucleus in the center. So with that, I could get the nucleus to separate. Then I moved to the other side to propagate the chop through and through.
Remember, I'll show you the other day, dial instead of pulling it.
Yeah.
So then you can get to the center.
Satu I want to ask, is the chopper is not in the set?
This one it was, but I think the scrub was used to passing me the Sinski.
Oh yeah, so, it's in the set lah.
Yes, it was.
You make sure macam you get to know like sebab all the instrument set tu, I think they got chopper in it.
This one, so initially when I was past the Sinski, I thought maybe I give it a try with the Sinski. Yeah.
You know the reason why we use Sinski? Dekat KKM kan, outside kan, they don't have money to buy all these choppers. So the most available instrument is Sinski. Setiap set kan. So they standardize the technique. So and in the end, everyone is using Sinski. So sebab chopper tu ada 2-3 je orang beli sebab tak cukup duit.
So kita cukup duit so pakai chopper. Belajar.
Dalam set tu ada chopper.
Kita tak ada cukup, I think Uttarata, tapi I rasa we resolve that dah kan.
Banyak chopper kita.
Uttarata.
Oh, Uttarata banyak.
Oh no. Okay.
Uttarata dekat pesawat Cataract banyak. Dia yang Mizan cakap itu tak ada tu sebab dia tak tahu. Dia ada yang bengkok yang musket tu kan, musket yang lurus. Ada dua, yang straight dengan curve. Yang straight tu yang ada habis sikit kot. Yang curve tu ada lagi. So boleh alternate use tu.
So I am still actively learning to tell myself to do the horizontal chop of the bigger.
And you shouldn't use that if you use chopper. So,
yeah.
Remember? You can't use that. Sebab chopper, you make hook something else.
Okay, all right.
You
can use that.
You didn't push your nucleus dengan your probe
I try to maneuver with second instrument whenever
you can move it with the probe. You have tried sebab I tak nampak you do it here.
Okay.
Tak biasalah.
Because I try to minimize the main probe movement because I scared kalau stretch the wound. Kalau stretch the main wound so usually I do struggle a bit in dialing, especially the heminucleus with second instrument, but sikit-sikit boleh lah doktor.
Kena belajar juga dah with your probe. Then I think your wrist can be more flexible. Sebab when you're going to do temporal, that's where your stretch is being stretched. Your wrist is being stretched to the maximum. Sebab you can bend your wrist to more.
Okay.
Nanti you rasa lah. Okay.
Oh, okay. Okay, doctor. So for this second heminucleus, it also when uneventfully managed to get all of them out. Patient, as you can see, has minimal cortical matter as well. So after removing what remaining nucleus, we went on to the cortical matter removal. So down there, what I was trying to flush is there's this little bit here that was hidden underneath at the sulcus, underneath the iris. So I was trying to flush it out, that little segment, but it was stuck there. So then I went to that area to try to get it out. Then subsequently, remove cortex, and there was a lot of little scanty cortical matter which I didn't dare to excessively polish as well. So
is the time in the screen is your surgery time?
the time in the screen as in the timer?
Yes, the timer.
Yes.
Yeah.
Yes.
So it's 15 minutes.
Yes.
All right.
So I was trying to grab hold so that I can go to the far edge to get that little piece of.
Are you giving intracameral anesthesia to this patient?
I usually will flush the vision blue out with intracameral lignocaine.
No. So your mode of anesthesia is intracameral lah.
Yes.
Careful about gripping the patient's eye. Nanti patient can jump because it's painful.
Okay. Alright.
15 minutes through the surgery, takut the lignocaine dah wear off.
Okay.
Remember that your tangan kiri jangan gatal-gatal, pitch here and there. Patient have little analgesic effect.
Okay. Alright. So after the cortical removal, I open up the bag. And then this patient was planned for ultracert 19.5, which is a preloaded. So during filling in of the viscoelastic and all, I checked. It wasn't shown in the screen. I think it was slightly outside the surgical field. I've checked both haptics were tucked on top of the optics. So over here, but when I injected, I noticed it was already stuck at the plunger. So I stopped for a bit.
What lens is this?
Ultracert.
Ultracert?
Icon tu lah.
Then I tried to slowly, gently, as much as I can, very slowly push the plunger. I tried pulling it back. The lens doesn't move. So it's quite tightly stuck, especially at the neck area between the
Did you all preheat the lens, letak dalam pocket? Tak ada. Ultracert has problem. I prefer. This is actually IQ, man.
So then
sekarang have this kind of problem, or do you put enough viscoelastic in the?
I put until it overflowed from the tip.
I think overflow pun sometimes cause you problem. You just have to put.
Alright, okay.
So this is where this is
very rare nak putus with Microsoft lens.
Sekejap, sekejap. Oh, I think I saw this patient.
Yes.
Sekejap, stop here. You know, some surgeon, if they get stuck at the tip like that, and of course, not for you all to try. Some surgeon will cut the cartridge. You know, using the 15 degree. Of course, it's dangerous. Probably not. Probably don't do it.
Okay.
Cut the cartridge, meaning it's open up. The cartridge is or the tip there start slicing, and particularly they open up. No, they open up. They need more space for it to go through. So instead of pulling using your forceps again.
Yep.
So some surgeon will cut the cartridge instead. Okay, 15 degree. Tapi of course it's probably good hand only do that. So when you cut the tip there, dia jadi longgar kan ujung kan, then only you push. So that's the tip.
Because I also tried to advance the plunger. It's advanced to its maximum. It couldn't come out anymore.
Did you try to pull and push? Pull.
Yeah, and you got this kind of problem. Don't push it to the all the way.
Pull, retract.
Retract dulu, push. And retract dengan your Kelman. You try to pull it slowly, a Kelman. Tapi don't push all the way. I would not recommend it. Don't push all the way. Then it will get more caught up. Then tighten like this. Then it will break.
Okay. All right.
This is what I told Alcon about this
ultracert.
Preloaded ultracert. There's no point doing this ultracert when their IQ is already perfect. So when they try to market this, ada problem. And
I think if you put too much viscoelastic, nanti the lens to float, so it's not in its. It's not. It's macam indicated macam original position sangat. That's why I think boleh sangkut your.
Ataupun dia tak panas kan? Selalu dia it needs a bit softer lah. So panas kan? I always say kalau ultracert dia masuk pocket.
Okay.
Letak belakang PC, heat it up a bit. Then okay. Kalau tak ada masalah. Okay, go on.
So over here, that time when we called, when this happened, then we called and consulted Dr. Aziz. So I managed to pull out the remaining tail, but with much effort to try to really pull it out. So it was really stuck. So at this point, I left the remaining leg out here.
I think in my experience, you are the first yang broke Microsoft lens. Tak pernah jumpa. It's the most friendly and soft, easily manipulated lens.
So at this time, because I'm not too sure whether to remove the lens or whether we will what to do, so I injected more visco to sort of float it up to the anterior chamber in case easier manipulation.
You never encountered this problem before with your
no,
consultant?
No, usually I'm more comfortable with manual loading lens.
Ayah. What do you do ni with this case?
So in this case, we consulted Dr. Aziz. Dr. Aziz said because the optic haptic junction is not affected, so this one I already done.
Dia tak patah completely dekat optic junction kan. So it still have something to hold. Betul tak? Kalau let's say dia patah macam 3 piece kan, sometimes dia patah tertanggal dekat junction tu kan. That one you have to explant because it's not stable. Macam ni kan, it has some haptic still kan. Even though it's not round, but it can still hold. What happened to this patient?
So this patient, when she came back, so this is when Dr. Aziz said implant, so I implanted and gently maneuver. She came back on day 1, vision 636, but there was slight edema. Her 1 month post-op, I'm waiting for her 1 month post-op, which is in 2 weeks' time. So
I was stable at that time.
Yes, tapi triple myo, so hard to look at the optic margins. So Dr. Aziz mentioned to put it at straight 12 and 6 o'clock. So this is what I'm trying to slowly down and
to be okay.
Try to put it.
Why you put it at that position, Shu, you think?
Because the inferior haptic is still intact. We can still, at least with gravity 12 and 6 exactly that way, the lens hopefully can have a chance of stability.
Yes, betul. But later, what will I do? I will remove the viscoelastic completely.
Yes.
And the back will be flattened on the lens. So hopefully the lens doesn't move. And we put the haptic, the unbroken one at the inferior, so that when the gravity full, it still stand.
Yep.
Tapi I would also constrict the pupil. So
yes,
more pressure on the lens, hopefully with the back and the iris compressed on it, so the pressure, the lens will move lah. Okay.
So then I was trying to remove as much visco as I can. So I was also like trying to tease it from the side of the lens to try to remove whatever is below, because the viscoelastic was not Hilon, so it doesn't come as a chunk. It comes bit by bit. So as you can see, there's still quite a lot behind. So I was trying to tease the viscoelastic out.
How to overcome that?
I went to I didn't dare go behind, but I went to the edge to sort of tease with the aspiration fluid, the irrigation fluid.
What you can do, stop, aspirate, come out.
Okay.
Give it a few 10 seconds like that. You will see that the viscoelastic from the back will float.
Oh, okay.
Give it time. Jangan gopo. Don't rush. So you stop, keluar your probe. Dan nanti you nampak slowly the viscoelastic itu akan keluar. Or sometimes you just fill the AC with BSS.
Yeah,
like this. Then you see nampak, you will float out. Then you aspirate again. IA balik.
Okay. So at this point, I was just trying to flush out whatever remaining there is to bring it out. But generally, most of the viscoelastic has already come out. Yeah. at this point. So then myostat was given to the patient. And then I saw the patient post-op with the myos pupil, the IOLs appear stable. So I did tell her and warn her about the aggressive, and not lifting heavy, not being aggressive, and just try to be a good patient.
This is aspheric IOL kan, not that word.
Yes.
And yang patah tu, it's not patah at the junction, so it still has some haptic there to hold it. Of course, you need the full haptic to stretch the bag, right? But this one I think should be okay. If it's patah dekat junction, you must explant already.
Okay.
It will not be stable.
So this is a bit of myostat, I think, to constrict the pupil.
Learn lesson, Joe, when you inject this preloaded kan,
Yep.
dia bukan one way push je tau. Most of the IOL, it works by retract, push, so that you don't want that to suddenly, the haptic goes to the wall and it gets stuck. So retract push is generally safe for all preloaded, and in fact all IOL, I think.
Okay. Then so ended the case with intracameral cephaloxime. Yeah. So I will update again after the patient come for 1 month post-op review to see how the IOL and the condition is.
Alright, good.
Ada lagi video ke ni? Habis dah?
Habis dah. Tak bisa lagi kan? Cukuplah. Dah lagi kan?
Okay.
Dah
Tanya
lagi.
sikit, why your choice of placement of the wound, is it influenced by the K reading or it's just your personal choice?
Because previous mentors all have been around 11, 12 o'clock. So I have experimented with in the past with 10, 11, 12. I find 12 and 3 okay. There's no qualms about 12 and 3 for me, so I'm okay with it. So I just proceeded with it.
Okay, I think the logical thing is the angle between your second and first spot is the angle between you. If you put your hands together, you look at the forearm. Your forearm, what is your angle? I think that's the most comfortable position for your angle, for your hand to work with. The problem with putting at 12, when you do IA, you notice you tend to rotate the eyeball up and down, okay?
Yep, okay.
Because the angle of your wound is superior, but your hand is at the temporal, right? Or on the side.
Okay.
The other problem, when you rotate so much of your eyeball when you did IA, because your probe was not enough.
Okay.
Yeah?
Understand.
So you tend to push it to the side and to the left, to the right.
Okay.
You can't reach your cortex.
Okay, understand.
Okay. Yeah. Okay. This is my personal opinion about the chopper and the Sinski. You can use both, but in this case, I think it's better to use the Sinski because it's not soft. So usually my choice would be, if it's softer, you go for the blunter instrument. Harder, you go to the sharper. Sinski is not sharp. Sinski is small, but it's relatively sharp compared to the chopper. So the problem here is because I think your first groove was not deep enough.
Okay, alright.
Okay. Okay. Thanks.
Ada lain? I think last video ada soalan, ada komen from others. Ishak, Stella senyap. Stella.
Selamat pagi. Saya rasa tak tahulah bila saya ni kan, bila the angle of wound, main wound dengan paracentesis about 90 degree, macam Shuyi punya position ni, dia punya cracking tu is not dialing motion tau, it's gonna be like pulling. You see, kalau tak tahu, ikut my logic lah, because
pulling.
Kalau you dial from this position, it should be dekat pukul pergerakan between 7 to 10 o'clock, betul tak? Because it pivots dekat you punya fingers. So kalau bila you tengok macam ni, it's actually bila you tarik, dia akan jadi act of pulling instead of dialing. It's not, tak tahulah. Kalau katalah position 10 and 2 or 11 and 2, barulah To me lebih comfortable lah. This is macam awkward. Tangan you kena macam berkepak sikit.
Yeah, I think
Anyway.
I think the more acute the angle, the more limited your movement. Okay, so if it's this wider, it's easier for you to move about. Okay, so
Understand.
But it's not wrong as long as you are comfortable with it. Tak jadi masalah. Cumanya in long run kalau you nak buat macam ni, well, it's all up to your preference lah.
Because this thing also influence other things. Kalau you know, let's say you want to do VR later on, it doesn't work that way because your hand will not be at 90 degree.
Okay.
So you have to look at, because for us macam for me that 90 degree will not work because my position will not that way. I mean, I do vitrectomy, so you have to look at other things. And then
betul nanti you wear off your wrist. You still young,
so
tak rasa lagi.
Nanti so you look at your hand, you hold your hand together, look at your angle, at your forearm. Is it that is the most comfortable angle?
All right, understand.
Okay, right.
Understand.
Alright, ada lagi Amira, Tikin. Stella, senyap Stella ni. Ada Stella? Tak ada dah Stella.
Hello, Assalamualaikum.
Okay, go ahead. Hafiz, okay. Go on.
Hello, Hafiz here. I got a question actually. Can you hear me?
Boleh Hafiz, can.
Okay, yeah, I got general question about backup lens available in Mawib. Whenever you do operation, you do have a 3-piece and SUL available kan in Mawib kan?
Ada consignment.
Macam yesterday actually we got one referral drop nucleus. We already did the operation lah, and then I think we can help to implant the 3-piece IOL. So boleh tak lepas ni kalau macam whenever got referral to us for whatever reason lah, drop nucleus ke apa kan, and the eye is FPK, boleh tak hantar sekali 3-piece and STIOL?
Kenapa semalam you tak minta ya Hafiz?
Kena minta semalam. Kena minta.
That's why lah yang tu tak tahu, and then
dia tak datang automatik. Hafiz, dia tak datang automatik.
Awak lupa
consignment.
Tak tahu itu Dr. Khairuddin yang buat operation tu, saya pun tak perasan. And then masa tu baru tahu patient tu ada 1 piece saja. So the problem is macam whenever they refer to us, dia tak settlekan sekali dengan scan. So kalau nak minta 3 piece pun kita tak tahu nak minta lens power apa semua. So I think this thing should be settled before the patient be sent to us.
Siapa MO yang receive? Siapa MO yang kelak?
Dia kena prepare tu. Dia macam ni Hafiz dulu ada consignment.
It's okay. Because that was this is not a normal time kan, macam we just have to accommodate with current pandemic. So usually lah, usually I will ask, okay, this is maybe partly of my fault because I minta dia hantar cepat, with or without lens, send, we do it straight away. So this is a total different scenario lah. So we don't want patient to stay at home. And you know the circumstances of the patient kan. So usually ada. So yesterday the day before I did ask whether there was any capsular support or not. Tapi technically the person who sent tu sepatutnya dah fikir lah kan what to send it with apa semua kan, because we want to do it immediately. So I think looking at the whole total scenario tu, I think you would understand why it happens that way lah.
Tapi
so secara logiknya memang akan ada backup lah. Selalunya we request
selalu ada
3 piece.
Tapi dia dulu consignment dekat daycare ada satu. Sebab daycare kita tutup, so tak ada lah. So dia ambilkan keluar benda tu. So
ni
yang
Hafiz, consignment kita memang kat daycare. Sekarang ni memang susah nak ambil. Tapi kalau anybody nak cuba nak dapatkan 3 piece without